Hi, I'm Scott Jenkins, Executive Vice President of Partnerships of Plan LED, and it's a real pleasure to be here today with Dr. Ed Nardell, who's recognized worldwide as a leading expert in upper room germicidal UV. So we've got a few questions here from Ed that we're anxious to hear about. So Ed, welcome, and thank you for joining us today.
Thanks, Scott. It's good to be here.
So Ed, we all look at the CDC for guidance, and they recommend 6 or more air changes per hour for indoor spaces to reduce the risk of infection from airborne pathogens. We know most spaces fall way short of meeting this. What do you think should be done to make spaces safer?
Well, the CDC guidance has been pretty much the same for decades, and really was generated around tuberculosis. I think 6 to 12 is a lofty goal if you're talking mechanical ventilation, and at the same time, in many circumstances, if you have a highly infectious pathogen like Omicron variant and some of the newer variants, it isn't enough. And yet, it's hard to imagine practically through ventilation alone to increase more than 6. And 12 is even very ambitious. Hospitals can do it, special ventilation systems. So the alternative is to use room air cleaners, which are also somewhat flow limited. The amount of air you can get through a box and filter or somehow disinfect that air, or turn to germicidal UV, which has tremendous advantages in terms of the volume of air that can be disinfected at any one moment. So you're irradiating and disinfecting a good portion of the room continuously, and that air circulates throughout the room. So it's more effective, I think, to achieve those kinds of numbers, and more likely to make a difference, particularly for hyper transmitters, super spreaders. Yeah.
Great. You know, obviously we're all kind of tired of masks and vaccines and all the rancor that comes with that, but we know they're effective at preventing illness. But we seem to be tired from those preventive measures. How significant of an impact can upper room GUV have to help fill that gap?
Well, first of all, and I agree with you entirely, Scott, vaccines you always have with you once they're in your body, and you carry that protection, and it's going to keep you out of the hospital by and large. And that's really critical, the single most important thing we can do. After that, masks are also quite effective, but you can't wear them all the time. And so we find countless places of interaction where masks no longer are possible. I mean, are not being worn, of course, restaurants, bars, social gathering places. Occasionally people will be wearing them, but really you can't eat with a mask on, so it's going to have to come off. Airplanes, for example. So the mask is an incomplete approach. And even though I think they have a very important role, particularly for high risk individuals, it is ideal to do something more than that. And again, we come back to disinfecting the air, which doesn't require cooperation, can be done when people are eating, and is in addition to vaccination, which, by the way, doesn't seem to prevent infection that well. It does prevent serious illness, but we all know lots of people who, by now, almost everybody's been vaccinated, and still people are getting mild cases of COVID, which are not insignificant, by the way.
Sure. You know, the threat of COVID-19 variants that are even more infectious seem to be increasing. The US currently has about 45,000 people hospitalized, and about 500 people a day are dying still. Upper room GUV is a very effective means of slowing transmission. What needs to be done to get this proven technology more widely deployed? Why don't we see more of it?
Well, what needs to be done is exactly what we're doing, in the sense of a greater awareness. Um, Basically, building operators, owners, engineers are not aware of germicidal UV in detail. There's a lot of misinformation around there about its safety and efficacy. It's been changing. There's a lot more attention in the last 3 years to germicidal UV, and but there needs to be formal training programs for technicians. There needs to be a public uh, training or not training, but public awareness program to basically make clear that there's a distinction between the UV that you're exposed to out in the sun, which can cause skin cancer and cataracts, and the UV that we use for air disinfection, which is essentially doesn't do that. But people lump it together as UV. So I think number one is greater awareness and technical expertise, and you know, funding is an issue, particularly for places like homeless shelters and places that really need it. But coming up with capital funds to make any major improvement is always a challenge. And there is some money around now for COVID remediation, but that's disappearing.
Sure. We hear about the layered approach to filtration, ventilation, and now air disinfection that really makes up the three main means of delivering indoor air quality. Knowing that we also need to be mindful of utility expenses and carbon emissions, it seems that upper-room GUV may very well be the proven technology to solve for all three objectives. Um, how do you view upper-room GUV in terms of the complete solution, not just disease control, but energy and carbon emissions?
Right. So, as you know, if you provide 6 to 12 air changes and have to heat, cool, dehumidify that air, that's a very costly proposition. Um, a lot of systems in cold and hot climates don't take in 100% outside air for sure, but it's still much less expensive to disinfect the air with germicidal UV. Now, you need ventilation anyway, so you don't eliminate all ventilation costs. Certainly, heating and cooling costs are there, but you can certainly you can provide comfort levels of ventilation that provide cooling and heating, and then provide germicidal air disinfection for the air disinfection part of it. And I think that's a rational strategy. Department of Energy is very interested in germicidal UV and is investing quite a bit of money in developing germicidal UV upper room, and I think ultimately also the whole room UV, primarily because of its cost saving potential and greenhouse gas saving potential.
Sure. Recently there was a publication regarding the speculation that GUV could create some VOCs, volatile organic compounds, in the space, and we know safety is absolutely critical. What's your perspective on the safety of GUV?
So I'm aware of two papers, and one which looked for evidence of VOCs in rooms with germicidal UV and didn't find any. And then the same authors came back and wrote a theoretical paper arguing that if there were VOCs that could be impacted by germicidal UV, that could undo some of the benefits of germicidal UV. In that paper, there's a lot of suppositions, assumptions, and those are subject to discussion, I think. There's no evidence of that. I'm aware that for 70, 80 years, we've been using upper room germicidal UV. I would think in the course of that time, particularly since I've been involved in this personally for such a long time, that we would hear about instances where there were bad odors produced, or there was coughing induced, or there was burning eyes induced by the generation of chemicals in the room from VOCs. And frankly, I can't find any reports of that. I am aware of one instance where aerosolized drug was converted into an odoriferous drug or compound by germicidal UV, and that situation was resolved by ventilating the space. And this was in the early days of the use of pentamidine for AIDS patients. Ventilation is the answer to that, by the way. If there were VOCs, which there are from off-gassing of carpets and plastics, etc., these need to be removed by ventilation. And so we are saying there needs to be ventilation anyway. And I think that's by and large solves the problem of unwanted VOCs. More work needs to be done in this area, and it's an issue that's been raised and needs to be resolved.
So, in a typical space, you've got ventilation, you've got some filtration. If you add air disinfection, what I hear you say is uproom GUV is proven to be safe over a long period of time. And if for some reason it did even introduce VOCs, your ventilation would reduce that concern.
Right. And I think, there are a lot of, one can raise all kinds of theoretical concerns, but I think we do need some actual evidence that there's a problem to fix. And we haven't seen that yet.
And tell us a little bit about how long this stuff's been out there in use. I mean, I guess there's studies dating back to the 40s even.
Right. So if you realize that in the 1940s, um, Wells and Wells did a study of measles transmission in schools, and it wasn't brand new technology then. It had been in use long enough that they were able to get commercial fixtures and put them in the schools in Philadelphia, outside of Philadelphia. This is not a new technology, and since we're in 2023 now, we're coming on close to probably about 100 years this technology has been in use. And really, the major problems that have occurred over the years have been accidental. Someone climbing up on a ladder and looking directly into a fixture. So there needs to be training of staff. Some people putting a fixture in upside down. We need trained technicians to make sure that doesn't happen. And of course, things happen with any kind of device, electrical or whatever, that can impact safety, and we need to take every precaution to make sure that they are safe.
You mentioned earlier about UVA and UVB and them being, carcinogens. C is not a carcinogen. And if you were to be overexposed with it, it's really just a temporary sort of irritation, if you will, that quickly subsides.
That's correct. Now, we have a little bit of a transatlantic difference of opinion on this. The IES, the International Illumination Society, that's based in the US, has a very strong position paper that says UVC is not carcinogenic, and it's based on lots and lots of animal studies and human exposure. And in fact, there's even a calculation there that says, yes, you could produce a skin cancer with germicidal UV, but it would take approximately 300 years exposure. So not likely to happen. On the other hand, in Europe and in Germany in particular, there is an opinion that basically, if something can cause at whatever level, if there's any carcinogenic potential at all, we don't want it around. And so they've been very reluctant to adopt this technology. But in fact, you have to, I think, look at it from a risk-benefit perspective. We know that COVID-19 is causing long-term health effects in addition to the acute effects and the loss of education and socialization. And so we have to balance the minuscule risks, as you say, of eye irritation or skin irritation by accidental exposure, not as used as intended, by accidental exposure against the benefits, which are enormous. So, you can also stick your hand in a ventilation fan, and not a good idea. And so training needs to be done to make sure those kinds of things don't happen.
Sure. And with upper room GUV also, it's a light source that contains the light in the upper regions of the room away from people. So to be clear for people that might be listening to this,
That's
thinking, oh
right.
my
This is
gosh, we're
not,
exposing people, they're not
this
really being exposed to it.
right. This is not being shown directly into the room. The intention of the design of fixtures is to keep the UV in the upper part of the room and out of people's eyes. And there are very solid guidelines of how much exposure people can have at the eye level, which is the most sensitive part of the eye. Now, one comment here is that the guidelines are actually overly strict in the sense that they assume that people are looking at the fixture like continuously for 8 hours or even 4 hours, which of course isn't the case. Most people are walking around a room, or if they're at a desk, they're looking down, they're not looking up at a fixture up on a wall. And so the actual exposure to skin and eyes is a tiny fraction of what the 8 hour stare time would be. And we've shown that by direct monitoring. The highest level we could measure in any individual was about a third of the TLV, so quite safe.
Great. Ed, I know you made some comment about the last question. I'm going to ask it, and you may feel free to kind of change the answer here about the TB and the amount of dosing. But we are recommending half of the dosing for TB based on the recent German study on COVID susceptibility with UV. This would limit GUV's effectiveness to viruses, but it will be more economical and reduce the chance of occupant exposure. What are your thoughts on that?
Well, I think there's actually going to be I think it's, I'm trying to remember which organization, there's going to be a federal committee to examine standards for air disinfection. In other words, how much protection is enough? And that is not a scientific answer. That is um, a consensus. Are we happy with 90% protection, 95% protection? Again, we talk about multiple layers. So one of the questions is, do we go for a lot of protection and increase the cost, or do we go for lower levels of protection and spread that protection more widely? And I think there are always practical decisions to be made. If you have a school and they either are going to be able to do half the classrooms or all the classrooms, and at a lower level, one may choose to do what you're suggesting and do half the output and have fewer fixtures and achieve a lower level of protection. Um, my own view is that these fixtures are intended to be in place for the long term, and one would not be able to predict what the next pandemic is going to be. If we were to shoot for the susceptibility of tuberculosis, which is less susceptible than most viruses, then I think we've got pretty much everything covered, but maybe at the price of overkill for COVID, for example. And so I think those are reasonable decisions that people could make. And it's the same with ventilation. You can, keep the ventilation system you have and run it at 6 air changes, or you can run it at 12 air changes, and if it's possible, and you'll have to have a big difference in the operating costs and some difference in the protection that you'll get. And there's an old saying in public health that public health is purchasable. You have to decide how much you want to spend, and you end up with what you've paid for. So I think, putting in some germicidal air disinfection is certainly better than none. And if you're going, particularly in a poorly ventilated school, to go to 6 air changes an hour with fewer fixtures is a huge improvement. In fact, you get the biggest bang for the buck at the first increase in air disinfection. After that, you're gilding the lily. You're adding relatively less and less for more and more cost. So at some point, you have to say where your cost benefit falls out. So I understand what you're doing, and I think it's a reasonable option.
And one thing I think that's helpful for people to get a perspective of it too, one fixture in a classroom of less than 1,000 square feet, it's easy to achieve 10 or more effective air changes per hour in trying to defeat the COVID virus or a virus. Whereas with TB, obviously it's a lesser effective air change per hour, however, still significant and can easily push you up beyond the 6 air changes per hour that the CDC recommends. So,
Right.
so it's not like we're putting two in a classroom. One in a classroom is going to get you a great result, whether you're looking at TB or whether you're looking at some airborne pathogen like a virus.
Scott, you haven't mentioned this, but with germicidal UV, we sometimes calculate rates of equivalent ventilation as if the ventilation were 20, 30, sometimes more than that. So we are working at orders of magnitude of air disinfection that are really unachievable through mechanical ventilation. So even when you back off, you've still got a lot of air disinfection.
Yeah, and I think that's the beauty of really taking the layered approach. The typical HVAC system of delivering indoor air quality is ventilation and filtration. And that's the beauty of adding a proven air disinfection technology like upper room GUV, because you really do have a powerful tool to deal with the pathogens. Of course, you still need the filtration and the ventilation, but the combined gives you really a much more optimal solution at an affordable cost.
There isn't yet much evidence at all of recirculation of COVID through ventilation systems. And yet, some school recommendations have been for upgrading to MERV 13 filters. Now, there are some good things to come out of better filtration in terms of pollen and maybe some pathogens that are recirculated, but COVID has not been shown to be recirculated to date. Uh, there is evidence of finding virus in the ventilation system, but we don't have any reports of people in different rooms in different parts of buildings being infected without any other form of contact. That happens with measles, it happens with TB. So far, it hasn't been reported with COVID-19.
And I suppose then that's another advantage of upper room GUV. You're taking the treatment in the room where the threat is.
Absolutely. The first of all, if I'm in the room with you and I'm infectious, it's not very comforting to you to know that the air will be disinfected when it leaves the room. You want the air in the room to be disinfected as rapidly as possible.
So Ed, we hear about these variants and things are emerging. China's opening up again, and who knows what the next epidemic might even be. How do we know that what we're doing to deal with COVID today is going to be effective against variants and future threats that we might face?
Well, fortunately, we've known from a long history of germicidal air disinfection that susceptibility of organisms doesn't change with mutations. It's determined by a variety of factors having to do with the size of the organism, the nature of their nucleic acids, and perhaps whether they like to exist in humid or dry environments, etc. But the actual susceptibility is not expected to change at all with mutations. So if you have something that was good against the original, if you have UV that was effective against the original strains, it's going to be effective against the current strains. The one difference is that I think the more infectious a strain is, the perhaps the greater the equivalent air changes you'd like. because simply there's a greater chance of spread. So I would say that the current um, Omicron variants would make one think more about germicidal UV and less about mechanical ventilation as a way to mitigate in rooms because you're so flow limited by air cleaners and by room ventilation. That there was this what you're suggesting, that air disinfection is a public health intervention, much like water disinfection was introduced early in the almost at turn of the century, I suppose, the last century, um, around 1900 or so. Water systems became subject to disinfection, by the way, which UV is a huge part of water disinfection. But at any rate, early public health folks thought that we would do the same with air disinfection before there was measles vaccines and polio vaccine, et cetera. People were thinking that this would be the approach. And then when those antibiotics and vaccines came out, enthusiasm for disinfecting air became less so. And also the challenge, I mean, you have water coming from a source, you have air coming from many sources. So it's a lot harder task to do. But I think there are people now talking about that, there ought to be a building standards that says that, in public spaces that we need a cost-effective way to prevent epidemic transmission. We know that some things work. We knew that during the height of this pandemic, wearing masks and separation worked. And now we want to get back to business as normal. We want something to prevent that transmission still. And to me, the only option at the moment that is cost effective and implementable is germicidal UV. And, I think there are people who are expecting this to be more widely spread. Department of Energy, for example. The White House itself is there's an Office of Science and Technology, um, very, very up to date on the UV situation in terms of understanding how it works, the advances that have been made in germicidal UV, and they are part of this movement to determine how much disinfection we need and how to measure it, whether it's equivalent air changes or something else, and what the standards ought to be for public buildings going forward.
And one of the most infectious pathogens that I've heard about is measles. You hear that quite a bit. The 1940 study outside of Philadelphia, there was actually a pretty significant reduction in infection rates with rooms that were treated with upper room GUV. So, it protects you against very transmissible pathogens, whether it's seasonal influenza, COVID, measles, tuberculosis. I mean, I guess that's another advantage of this kind of treatment. It casts a pretty broad net of protection.
Absolutely. I mean, you're absolutely right. Measles is considered the poster child, if you will, of infectious viruses, and really goes through schools like crazy. And UV was shown to be quite effective. There were a couple of other studies that weren't as positive in that regard, but in one of them, children were getting infected on school buses on the way home or to school, and in another in central London, they were getting infected in crowded tenements. So you can only disinfect air where the UV is in place or the ventilation is in place, and you can't guarantee transmission won't occur there. But our goal is to reduce transmission wherever it occurs, and for lots of students, the most crowded place that they'll be and exposed to other sources will be in school. So it seems like an important place to do it. They're home with their family, they're at risk, but the risk is probably much less so.
Sure. And in that example, outside of Philadelphia, was it something like a 70% reduction in transmission in
I
rooms
think it
that
was
had the
more than
treatment?
that. I think it was about 90% reduction, something like that.
Wow.
You know,
Well, Ed, it's always a pleasure to visit with you and always informative. We appreciate the great work you're doing to get the word out, to keep people safe in indoor environments. So thank you for spending time with us.
you're very welcome. Nice to be with you.